Module 3, Sinus Rhythms. In this module, we're going to look at the different types of sinus rhythms and start to look at the rules or the things that characterize a rhythm as a sinus rhythm or sinus tachycardia, sinus arrhythmia, etc. So up to this point, we've discussed the heart's anatomy and physiology. We've talked about cardiac output. We've looked at cardiac action potentials, the cardiac cycle, and where our EKG comes from. So it's important for us to understand before moving into sinus rhythms, the different waves, segments, and intervals that we can see when looking at an EKG, because the way that those waves and intervals look and measure out is going to give us certain characteristics of different types of rhythms that may make it a sinus rhythm or an atrial rhythm or a junctional rhythm. So that's important to understand that. So if you're still struggling with that, please go back and review the waves, segments, and intervals so that this will make sense for you. A sinus rhythm is a rhythm that begins at the SA node. If the SA node is the origination of that rhythm, then you should see some certain characteristics on your EKG. You should have identical or close to identical P waves, constant PR intervals. Your QRS complex generally should be narrow. The reason you may see some variations in the PR interval or P waves, slight variations, could be due to the patient's just individual anatomy, pathology, or maybe their current autonomic nervous system influence, if you will. For a sinus rhythm, technically it's not considered an arrhythmia. It's just the normal state of functioning as the heart cycles through its automaticity and its depolarization and repolarization. So some of the sinus rhythms that we're going to talk about today are going to include a normal sinus rhythm, bradycardia, tachycardia, sinus arrhythmia, sinus block, pause, and arrest. First rhythm we have is a normal sinus rhythm. We're going to talk about some of the characteristics that make a rhythm a normal sinus rhythm. To start, let's look at P waves. So I'll isolate these P waves here. When I look at leads 2, 3, and AVF, I should normally see upright and identical P waves. And that's because the view that 2, 3, and AVF are looking at the heart from, they're perceiving this positive depolarization wave traveling towards the positive pole of that lead, and it's going to interpret that as a positive deflection on my ECG. So you can see above here I have P waves that are identical and all in a positive direction. So that's one characteristic of a normal sinus rhythm. Next, we have our PR interval. So our PR interval is the beginning of my P wave to the beginning of my QRS complex. So I can measure this PR interval, or this PR interval, I can measure this PR interval here, and I'm going to find that, okay, yeah, that's about 3 small boxes, maybe a little bit more. So 3 small boxes is within normal parameters because that's 0.12 seconds. So my PR interval in a normal sinus rhythm should be constant throughout the rhythm. So if I measure each of these PR intervals, they should be about the same length, 0.12 seconds. That would be a constant PR interval. Now, we know that this PR interval, it's actually a busy time in the heart because the heart's going through its depolarization and conducting that impulse, and the PR interval represents the delay that's occurring through the AV node that's allowing for the physiological block that slows that impulse down and allows the ventricles to fill all the way to the top, giving them max contraction. We'll take a quick look at the refractory period. So my absolute refractory period is really going to be this QRS complex, the start of this QRS complex to about my T wave. That's my absolute refractory period. During this time, the myocardial cells are going through depolarization, so they're unable to respond to an extra impulse because they haven't repolarized. They're in the middle of their depolarization, so they can't respond. And that's what's occurring in my absolute refractory period. Now my relative refractory period, from the start of that T wave to the end of that T wave, that's my relative refractory period. Now during this time, some of those myocardial cells have repolarized because they repolarize at different rates. And those repolarized cells or partially repolarized cells, they can respond to another impulse if it's strong enough. And the problem with that is that if that impulse occurs at just the wrong time, it could send the heart into a lethal arrhythmia, such as VTAC, or it could cause a premature contraction that we may perceive on our EKG as a very odd looking extra beat. Maybe the QRS is really wide, and that's because that extra impulse was initiated in a location other than the SA node. So it didn't travel the normal path of electricity, and our EKG monitor sees that as a very odd looking wave of depolarization traveling through the heart, because it's actually traveling from direct cell to cell contact instead of going through the heart's nice smooth electrical conduction pathway. The first thing we're asking ourselves is it fast or is it slow? If I was to pick one of these red, or in this case blue lines, I can use my 300 method. 300, 150, 100, 75. So my heart's right in the middle of that, so that's probably going to be about 85. We'll go 85. So I have a heart rate that's at 85 beats per minute. So we know normal heart rates are 60 to 80 or 60 to 100 beats a minute. So 85 is within normal heart rate limits. The next question is it regular or is it irregular? Well, I can look at this right off the bat and tell that this is a regular rhythm. I don't see any drop beats. The intervals between the R waves look consistent. Same for the P waves. See how they're consistent? We could take our calipers and we would march that out and measure that to know for sure that it's regular. But from here, we can tell from looking at it that this is a regular rhythm. The next thing I'm looking at is I'm looking at the P waves. I'm going to know a couple different things about the P waves. One, are there P waves? And two, is their morphology similar or identical? Well, I can see that these P waves look the exact same, and they're P waves. So yes, there are P waves and they are the same. Okay. This is also a good time to ask yourself, is there a P wave for every QRS? And I can count that and say, yeah, there's 1, 2, 3, 4, 5, 6. There's 7 P waves and there's 7 QRS complexes. So my P wave, my P to QRS ratio is a 1-to-1 ratio. Okay. Once I'm finished looking at the P waves, I'm going to move on to the PR interval. I'm going to take a look and I'm going to measure this PR interval here. And I can see that my PR interval starts about there and ends about there. And that's about 2.5 boxes. But for our purposes, we know that that's going to be within normal limits. And I would measure that PR interval at each one of these beats for consistency. And I'm really looking to know, is it constant? And I would find that yes, it's a constant PR interval. Perfect. And one of the last things I want to know is I need to take a look at my QRS complex. I really need to know, is it narrow or is it wide? All right. Well, a QRS complex should be less than 0.12 seconds or 3 small boxes. And I can look at this and I can see, yes, I'm really only about 1.5 small boxes. So we'll call that a 0.04 QRS, which is narrow. All right. So now that I've pulled all this information out of the EKG, I can really look at it and look at the characteristics of a normal sinus rhythm and say, okay, I have a rhythm that's within a normal heart rate range. I have P waves that are identical and upright. I have a PR interval that is normal in length. I have a narrow QRS complex, and I have 1 P wave for every QRS complex. I have enough information to justify calling this a normal sinus rhythm. So bradycardia is going to be any heart rate that is less than 60 beats per minute. So if it's less than 60, we know that we are dealing with a bradycardic heart rhythm. Now, if we look here in bradycardic heart rhythms, and we remember back to a cardiac action potential, phase 4 is going to be elongated. Phase 4 is going to be elongated due to the SA node firing slower. Okay, so we can see here on the EKG, phase 4 is this TP segment. So phase 4 is represented by the TP segment, and that's elongated in the sinus bradycardia. And that's because the SA node is firing slower, so there's more time in between heartbeats. With sinus bradycardia, it has the same parameters as a sinus rhythm, except the QRS complex can be wide, and that could be due to some sort of aberrant conduction as it moves through the heart's conduction system. So, for example, a patient that has a right bundle branch block, they could be said to have sinus bradycardia with a right bundle branch block. If the QRS is wide and within the normal heart rate, then we cannot call it normal sinus rhythm. We would just call that a sinus rhythm with a wide QRS for whatever associated reason. So some of the characteristics I'm looking for a sinus bradycardia are a heart rate less than 60. It should be regular. P waves and PR intervals should be constant and consistent. Like we said, the QRS can be wide, and it should still see upright P waves in lead 2, 3, and AVM. So if we look at this rhythm here and we start to dissect it, I can count. They'll say this is a 6-second strip. So I have 1, 2, 3, 4 complexes. So my heart rate for this is 40. So we know that that is slow. You can look at regularity. You can map my R to R intervals out here. We're going to find that this is a regular rhythm. So it's slow and regular. I have a P wave for every QRS, and those P waves also are similar in morphology. So yes, and they're the same. My PR interval, PR interval is about 4 boxes here. So PR interval of 4 boxes would be 0.16 seconds PR interval. Now I'd march that out and make sure that these PR intervals are all constant, and we could find yes they are. A QRS complex in this rhythm that we see here is going to be narrow. So it's about two boxes. So my QRS complex here is 0.08 seconds, which is narrow. And lastly, because I'm looking and I can see very clearly that I have a P wave for each QRS, so I have a 1:1 P to QRS ratio. So after pulling all the information out of this rhythm here, I can see that I meet the characteristics to justify calling this a sinus bradycardia, because I have a slow rhythm at 40 beats per minute. It's regular. P waves are similar in morphology, so they look the same. I have a P wave for every QRS. PR interval is within normal limits, and it is constant throughout the ECG. The QRS complex is narrow, so I can call this a sinus bradycardia. Now let's move to the opposite end of the spectrum and look at a sinus tachycardia. It's going to have the same characteristics as a sinus rhythm, whereas it will be regular, P waves that are the same, PR intervals that are constant, narrow QRS complex. The QRS complex in this case can also be wide and still be considered a sinus tachycardia. So there's that. So for it to be a tachycardia, the rate has to be greater than 100. Now, all of us, we have a maximum heart rate that our heart's going to be able to achieve, and that's calculated by taking 220 and subtracting your age. That's your max heart rate in terms of how fast it's going to be able to beat. Also, with tachycardic rhythms, we can see a slightly shortened PR interval, but we still find that it's within the normal ranges to be considered a sinus tachycardia. Moving into our TP segment, right, which is phase 4, in a tachycardic rhythm, the TP segment is going to be shortened. So you can see that very clearly on the EKG at the top of your screen. The TP segment is actually almost non-existent. Most likely, this is our T wave right here. This is our T wave, and then this little hump right here is our P wave. So we got a T wave and a P wave. And if we look at this, we see that it looks like the P wave is actually superimposed into the T wave preceding it, and it almost looks like a camel hump. Okay, so if you imagine like a camel's back, see how that looks like a camel hump, and that's because that the EKG is seeing basically two things occurring at the same time. The ventricular repolarization is still occurring, so it's capturing that, and it's also capturing this atrial depolarization, and it's infusing those waves together on the EKG. So in tachycardic rhythms, if you're thinking sinus tach, it's important to look for P waves that may be superimposed into the preceding T wave, especially if the TP segment has been shortened so much that you can't differentiate it. Something else to look for and keep in mind with a tachycardic rhythm, a sinus tachycardia, is there's something called our TA wave. So this TA wave is actually what represents atrial repolarization. And we typically don't see atrial repolarization because the QRS depolarization takes over the electrical view and just hides that. In tachycardias, because the heart is going faster, sometimes that TA wave starts to shine through and can cause some slight ST depression. So we can see our TP segment's probably somewhere right in here. So we're looking at about 1 millimeter of ST depression in this sinus tachycardia here. And that's significant for us, just as a reminder, to always do a 12 lead because this ST depression could also be significant for a myocardial infarction and not just a normal occurrence with this sinus tachycardia. So this would prompt us to investigate the heart rhythm a little bit further by performing a 12 lead. But if I was to ask myself the questions that I need to ask to determine a rhythm, is it fast? It absolutely is. 300, 150. So we're at about 160 beats per minute. Okay. Next thing I would ask myself is it regular? Well, it actually looks very regular. It's pretty consistent. I would march it out again, but I'm gonna go with this is a regular rhythm. Do I have P waves? Well, this gets a little bit complicated, but it actually does look like I can kind of tell this is probably the depolarization. There's my camel hump. So this right here is probably my P wave, and there's my PR interval here. There. So I do have P waves. They actually look pretty similar and consistent. So I'm going to go with yes, and those P waves look the same. Look like they're coming from the same place in the heart. My PR interval is going to be shortened here. So I'm looking at 2 boxes, probably superimposed. So I'm going to go with shortened PR interval. That's okay. I know that's considered shortened, and we're still going to be able to call this a sinus tachycardia. Question number 5. I'm asking myself, is the QRS narrow or wide? I can see here that it starts here. There's 1 box. There's about 2 boxes, so that would be 0.08 seconds. That's going to be narrow. Last question is my P to QRS ratio. Well, it's 1 to 1. Right? P wave, QRS, P wave, QRS. And that continues throughout this whole rhythm, so I have a 1 to 1 ratio. So I remember what it takes for something to be considered a sinus rhythm, which is that I have P waves that look the same and are similar in morphology. I have a constant or consistent PR interval, a narrow QRS complex, and I have 1 P wave for each QRS. So I have all the makings of a sinus rhythm, and because this rhythm is greater than 100, I'm going to call it a sinus tachycardia. So the rhythm we're looking at here on the screen is a sinus tachycardia. It has It is fast, it is regular, it has P waves that are similar in morphology, the PR intervals are constant throughout, the QRS complex is narrow, so we have enough information to call this a sinus tachycardia. Now, something that you commonly see in sinus tachycardia and other tachycardic rhythms is called electrical alternans. If you look really close at the QRS complexes, you can see that they are alternating in height from beat to beat, right? So that alternating of QRS amplitude is called electrical alternans. And really what causes that is the rapid contraction of the heart changes the axis of the ventricles slightly with each beat, and the EKG interprets that as a different amplitude from the QRS complex. So if you see something like this, it's electrical alternans, that is just a positive indicator that you do possibly have sinus tachycardia. So something to keep in mind is electrical alternans. The next rhythm is called a sinus arrhythmia. And in a sinus arrhythmia, what's happening is we're seeing this gradual widening and narrowing of the P to P interval. So we can see here, P to P interval becomes more narrow, and then compared to right here, P to P interval is further apart or a little bit slower. And this is how we can say that this is a sinus arrhythmia. In sinus arrhythmia, there's really two causes for this type of rhythm. One is a respiratory variant, and it's a result of pressure changes in the chest. We commonly see this in young kids because their chest walls are more compliant and just susceptible to different pressure changes. During inspiration, the heart rate speeds up, and that's because blood flow to the atria during this time is increased, and that triggers baroreceptors that are going to cause inhibition of vagal tone, decreasing or increasing the heart rate. During expiration, right, the pressure in the atria is decreased, so those baroreceptors are just no longer activated, and that causes the heart rate to increase. Now, a sinus arrhythmia is just a variant of normal, and it's not a pathological rhythm. So if it's the respiratory variant, like you see here on the screen, where you have a regular rhythm for the most part, except for it speeds up and slows down at different intervals, we can consider that a sinus arrhythmia. The other variant would be the non-respiratory variant, and that's when you would see the P to P intervals that just vary at random. There's no rhyme or reason that you can say this is most likely speeding up on inspiration versus expiration. That's commonly seen in elderly patients with heart disease. Lastly, on sinus arrhythmia, before calling it a sinus arrhythmia, rule out the possibility of just frequent PACs, or those frequent premature contractions making the rhythm irregular. So what we're looking at here is a sinus block. Now, in a sinus block is basically what it says. You have a sinus rhythm that's beating away as it normally would, and then suddenly it drops a beat, and the beat's no longer there. So you can see it here and here, that there should be a beat that occurs somewhere right in there in the middle. We would march that out, and we could say, well, here's my P to P interval. So here's my P to P interval. If I march that out, I should have another P wave that starts right about there, but it doesn't happen. And then I march it out again, the next P wave occurs at an exact multiple of that P to P interval. So you see how this rhythm is regular, there's just a dropped beat in the middle. That is what we would have the justification to call this a sinus block. So if I take my normal look at a rhythm and I ask myself these questions, is it fast or is it slow? Well, it actually looks like it's just a little bit fast. It's hard to tell with the way that we're looking at it here, but 300, 150, 100. So we're at about 75, so it's not fast. It's going to be within normal heartbeat limits. It's fast. Is it regular? Well, it is regular, but it's what we would call regularly irregular. It's regularly irregular because we have these couple instances that we're looking at where the intervals drop. So something's going on there. So that tells us we're going to come back to that. Next, I'm going to look at the P waves. I have P waves throughout the EKG. They are similar in morphology, so yes. This PR interval, in this case, is going to be a constant PR interval. You can measure that out there. So the PR interval is constant. QRS complex is narrow. I have a P wave for every QRS. I absolutely do. I have a 1-to-1 ratio. So I have everything I need to call this a sinus rhythm, but it's regularly irregular. This is what would trip me up and not allow me to call this a normal sinus rhythm. So I'm gonna come back and I'll say, I need to figure out what's going on here. And by figuring out what's going on here, I need to figure out when the block happened and when the new rhythm starts. And I would find that it's an exact multiple of the P to P interval, which would allow me to say this is a sinus block. And what's happening in a sinus block here is that the SA node is just simply unaware that the impulse was blocked before it continued to fire throughout the conduction system. So the SA node just fires again in its normal time on the next beat, and we see that beat pop up here. So SA node fires here, it goes to fire here, but nothing happens. It just doesn't realize that nothing happened. So then it just fires again in its next beat on down the line. So next we have a sinus pause or a sinus arrest. There's really no clear consistency on when you would call something a sinus pause versus a sinus arrest, other than if the P to P interval is greater than 3 times the normal P to P interval, we would call it a sinus arrest. For our purposes, we can use those terms interchangeably. The main difference, however, between a sinus block and a sinus pause or arrest is that the next beat is not an exact multiple of the P to P interval. So this top EKG here, I would try to march my P to P intervals out, and you can see I got some extra stuff going on here that we need to look at, but then I have this really long pause. It's really long pause. If I was to try to march these P to P intervals out somewhere in there, I would find that this beat here is not an exact multiple of what the P to P interval is. So that would change it from a block to a sinus pause. And then here we have a really long one. So because this is more than 3 times a normal P to P interval for the rhythm here, we would call that a sinus arrest. There can be multiple different reasons for sinus arrest, blocks, and pauses. Could be benign, like a sinus block. It can happen, and that's okay. Could be a cause of sick sinus syndrome that we'll talk about here in the next slide. Patient could have heart disease or some sort of inferior wall myocardial infarction that's leading to this, or it could even be myocarditis, which is inflammation of the heart.